Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Thank you so much for joining me, and also want to welcome our viewers on the replay. Merry Christmas to all of you and your families. If you have a loved one in intensive care over the festive season, you know, you absolutely have my sympathy, and you know we're here for help even over the Christmas holidays. We are open all the time because we know what it means to have a loved one in intensive care and looking out for help. So we're here for you even over the festive seasons, Christmas and New Year. Please reach out to us if you need our help. Now, before we go into today's topic and to today's questions, just very briefly, what makes me qualified to answer questions about intensive care, and what makes me qualified to answer questions for families in intensive care. So my name is Patrik Hutzel. I'm a critical care nurse by background. I have been working in intensive care and critical care for over 20 years in 3 different countries, where I also worked as a nurse unit manager for over 5 years, and where I have also been consulting and advocating for families in intensive care for over 10 years as part of my intensivecarehotline.com consulting and advocacy service. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we send critical care nurses into the home for long-term intensive care patients, predominantly ventilation with tracheostomy, but also for adults and children with a tracheostomy, no ventilation, but also for BiPAP, CPAP ventilation, home TPN, IV potassium infusion, port management, central line management, Hickman's line management, and PICC line management. Also palliative care. Okay, without further ado, let's answer the first question for today. And if you have any questions, please type them into the chat pad. And also, if you want to join me here and ask your questions live on the show, you can do that by clicking on the link that I'm just pasting into the comment box here. You can actually see the link, the StreamYard link. If you want to come on live on the show and you want to talk to me and ask your questions directly, you can go on camera here. And if you don't want to go on camera, that's fine too. We will be going for up to an hour. We'll go from here. Now, let's get into the first question that I actually had just yesterday. I just quickly need to look at my emails. Just bear with me. First question yesterday came from Diana, who says, "Hi Patrick, my question would be, although too late for my mum, but I wanted to know, when is having a tracheostomy tube too dangerous? My mother was very weak and I didn't think she'd make an operation. So turned it down, but always wondered if it would have woken her up so I could have at least said goodbye to her while she was awake. She never awoke. The nurse told me not to, as well, said it would have been too hard for me to care for her at home. Thank you for your valuable service," from Diana. Well, what a great question. Actually, this week, I made a video when not to do a tracheostomy. You can find it on my YouTube channel. I'll give you the exact title of the video that I've made this week. When can a tracheostomy not be done, or contraindications of a tracheostomy? So that question has been answered this week because we had it from another subscriber too. But so when is a tracheostomy tube too dangerous? Well, it's really only too dangerous if there's the following problems. A, FiO2, or oxygen consumption on the ventilator, is more than 50%, right? Keep in mind, room air, the air that you and I are breathing, is 21%. So 50% is more than double what room air is. So if FiO2 is greater than 50%, if PEEP is higher than 8 or 10, right, no one will touch your loved one for a tracheostomy. It's too dangerous. Okay, other issues when a tracheostomy cannot be done is when PO2 in the arterial blood gas is too low, PCO2 or carbon dioxide is too high, to the point where it's dangerously high, carbon dioxide, or dangerously low with the PO2. Other contraindications are like if your loved one is on nitric oxide, then tracheostomy also can't be done. Other contraindications can be a short neck, simply anatomical issues, right? If your loved one has a short neck, then a tracheostomy is also difficult to be done. Now, you are saying, when is a tracheostomy tube too dangerous? That's exactly what I said. Those are the reasons when a tracheostomy tube can't be done or is perceived as being too dangerous. Now, here's what you also need to know. A tracheostomy can be done on the one hand at the bedside in ICU. It's called a percutaneous tracheostomy, and it's done by mainly intensivists in ICU. And it's really a quick procedure, right? And number two, it can be done during surgery in the operating room by an ENT surgeon, right? So you're here saying, I didn't think she would make an operation. Well, I work with facts, as much as I have my personal opinions, but they're mainly professional opinions based on years of experience. Have you spoken to the doctors at the time? Did you ask them why do they think she can't have a tracheostomy? Did they give you facts like I gave you now? Was it the blood gas? Was it the FiO2? Was it the PEEP? What was it? Right? Simply saying your mum was too weak is a subjective opinion. It's not based on objective measures, right? So you said, so turned it down, but always wondered if it would have woken her up. It's not clear to me whether you turned it down or the ICU team turned it down. It's not clear to me. So I turned down, but always wondered if would have woken her up. So I could have at least said goodbye to her awake. So one of the goals of a tracheostomy is to stop sedation immediately. That's one of the goals of a tracheostomy. So let's just say, your loved one is on a ventilator with a breathing tube, is on fentanyl, is on propofol or Versed or midazolam or morphine. They're asleep. They're in an induced coma because it's so uncomfortable to tolerate the breathing tube in the back of the throat, in the mouth. So by doing a tracheostomy in the neck, right, it is much easier to tolerate. Therefore, sedation can be ceased immediately in most cases, right? So whether your mum would have woken up, I don't know, because I don't know your mum's condition. Maybe she had a stroke. You're not saying anything in relation to that. Okay, so it's not clear what your mum's condition was. How old she was. She never awoke. Did she not awake because she had a neurological condition, or did she not awake because she was on too much sedation? Was she in kidney failure? Was she in liver failure? Could she not process or metabolize the sedatives, and did she not wake up because of that? Now, you're also saying in your email, Diana, the nurse told me not to do the tracheostomy as well, said it would have been too hard for me to care for her at home. Well, I'll call rubbish on all of that. Well, you would know by now that we are providing a service, intensive care at home. Now, I don't know your location, Diana, but intensive care at home, we are sending critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, right? So we are currently operating all around Australia in all major capital cities, as well as rural and regional areas, right? So with that said, your mum could have gone home with a ventilator and a tracheostomy, and even if it was only for palliative care. When I say only, even if it had been for palliative care, so nurses also don't know what they don't know. They're blind to what's out there in the community. They can't think outside of their little ICU bed, outside of their little ICU world. They need to open their mind to what else is possible, right? So for the nurse to say it would have been hard for you to care at home for her, yes, I agree with that. If it had been you by yourself, right, you would have needed 24-hour intensive care nursing with intensive care at home. But that would have all been possible. So I hope that answers that question, Diana. What is actually possible at home and what is actually possible in intensive care. Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And I think, Diana, this is exactly what you are facing with, or what you have faced here. So let's move along to the next question. From Paul, who says, "Hi Patrik, my brother is 73 years of age, has been on dialysis for over a year, twice in a week. He had a heart attack 12 days ago. The ICU team implanted 2 stents in his artery. During the procedure, he had a cardiac arrest for about 8 months, or for about 8 minutes, before they were able to revive him. He hasn't been able to wake up for 2 weeks now. He sometimes opens his eyes and squeezes his hands if we ask him to. The neurologist said he will need a longer time to recovery, but his brain is good. However, they weren't able to give him dialysis twice last week." Okay, if your brother is a dialysis patient normally, and he had a heart attack 12 days ago, and he had 2 stents in his artery, and he had a cardiac arrest, probably his blood pressure would have dropped significantly, right, to the point where he needed inotropes or vasopressors such as noradrenaline, norepinephrine, dobutamine, dopamine, milrinone, maybe even some levosimendan, right? So now he hasn't been able to wake up for 2 weeks now. The question is, why? Is it because he has been sedated and ventilated, or is it because he had brain damage? So you are saying the neurologist said he will need a longer time to recover, but his brain is good. So that means they must have done a CT scan or an MRI scan of the brain, and they would have ruled out any neurological or brain damage, which is good. So if they weren't able to give him dialysis twice last week, I argue they weren't able to do that because his blood pressure was too low. That's what I argue, why they couldn't do it. So the remedy here is, have you spoken to a cardiologist? What's the cardiologist saying? They would have done an ultrasound of the heart, and they would have determined his ejection fraction. Ejection fraction basically means what the contractility of the heart is, basically in essence, how strong the heart can pump, right? And most of the time after cardiac arrest, ejection fraction is dropping. That means the contractility is impacted, which is often having a negative impact on the blood pressure, i.e. blood pressure is going down often, right? Bear in mind the heart muscle would have been damaged during a cardiac arrest, right? That's why your brother probably needs some inotropes or vasopressors such as, again, noradrenaline, norepinephrine, milrinone, dobutamine, or dopamine, or levosimendan to increase the contractility of the heart, and that could eventually lead to the place where your brother can have another round of dialysis, right? Because he's hemodynamically more stable. I think you urgently need to talk to a cardiologist here and make sure they're giving input. That would be my advice here. Now, next question from Macy, who says, "Hi Patrik, I'm very desperate to have someone see if there's any wrongdoing on the ICU's end. I can't shake the feeling deep in my gut that my baby girl, we were a victim of numerous things, including but not limited to negligence, carelessness, etc. The situation is much more complex than what people realize, myself included. What would something like that cost me to have you look over my baby girl's files for anything abnormal or that would raise concern? Well, that's a great question, and I'm very sorry, Macy, that your baby girl has passed away. I know you had sent me an email prior where I offered my consulting. Now, well, it really depends on A, how big is the file? So we would give you a quote to review the medical records based on the volume of the file, right? How many, i.e. how many pages? And B, we would base it on how many questions you want to have answered. It's as simple as that. It's as simple as that. But I also agree that, you know, when people go into intensive care, they don't see coming what is really coming. They don't know what they don't know, right? They don't know that it's a machinery, and they don't know what questions to ask, you know, what to look for. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And I couldn't agree more with you on that one, Macy, that people don't know what it is. It's like, you know, entering a different dimension, you know, and if you're not prepared, you will fight an uphill battle. So I hope that helps, Macy. And, you know, it's another testimony that you can't do your research early enough when you have a loved one in intensive care. You cannot, right? So let's look at the next question from Jessica. Jessica says, "Hi, Patrik. I have concerns about the hospital wanting to send my dad to an LTAC facility. He's currently in ICU for a TBI. TBI means traumatic brain injury from a car accident, and he's still on the ventilator at night. I just want to make sure I know what grounds I have to stand on for our rights for best care for my dad." Thanks, Jessica, for sending that question in. Well, two questions here. Your dad cannot go to LTAC without your consent. That's assuming you are the power of attorney. If your dad can make decisions himself, then you know, he shouldn't be going to LTAC unless he agrees, right? Now, here's another question though. If he's still on the ventilator at night, well, that means he's off the ventilator during the day, which is fantastic. So the question is, how far away is he from getting off the ventilator? He might be pretty close. If he's pretty close in getting off the ventilator, why would you even consider sending him to LTAC, right? Why would you not keep him there, and they need to take responsibility getting him off the ventilator? That would be a much better approach. A much better approach, right? So, you know, I would argue if he can get out of bed, and I don't know the level of injuries your dad has sustained, you know, if he can get out of bed every day and build up his strength, get him off the ventilator overnight as well. And then there's no need to talk about LTAC. Now, here's the issue with LTAC, going to LTAC with a ventilator and a tracheostomy and a TBI. The problem here is if he goes to an LTAC with those conditions, the focus will be on ventilator weaning and not on neurological rehabilitation. The much better case scenario here is to, you know, get him off the ventilator and then focus on neurological rehabilitation because of the TBI, right? You know, like I always say, you have to ask better questions. You know, what is the best case scenario here? The best case scenario is get him off the ventilator 24 hours a day and get him onto neurological rehabilitation, right? And more importantly, inform yourself about your rights. He can't go anywhere without your or your dad's consent, assuming you are the power of attorney. I hope that helps, Jessica, right? So now, if you have any question watching this show live, I encourage you to type in your questions into the chat pad, or if you want to join me live on the stream and you want to answer your questions live here, click on the link that I just posted here in the chat pad, and you can join me here. You don't need to go on camera. You can just talk away. It's up to you. If you just want to watch in, that's absolutely fine too. Okay, now let's move on to the next question. coming from Anthony. Anthony says, I can't let my wife go without knowing I've done all that could be done. Nothing makes sense when I talk to the doctors. Tomorrow is the final meeting with the doctors. Wow. Okay. Anthony, it's a very brief email that you send, and there's a lot of missing links here. Okay. And I agree with you. You shouldn't let your wife go without knowing you've done all that you could. And I can understand that nothing makes sense, because once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Once again, that is exactly what you're dealing with. My first question to you is, have you got access to the medical records? Right, that's the first question. Right, do you have access to the medical records? That's number one. Number two, have you sought further help? If you are genuine and serious in help, you would pick up the phone and call me on one of the numbers on the top of our website, and you would be serious about getting help, right? An email like that doesn't really mean anything. Now, you are also saying tomorrow is the final meeting with the doctors. Well, do you need to even go into a meeting? No one can take away life support assuming you are the medical power of attorney without your consent. That could be perceived as murder or euthanasia. It sounds to me like you're in the throes of the intensive care team, and you're just scratching the surface here. Right? It sounds to me like you're in the matrix without having realized that there's a different way. So the only thing that I can do here, Anthony, is, give me a call at intensivecarehotline.com and call me on one of the numbers on the top of the website, or send me an email to another email with more information to support@intensivecarehotline.com. Right? Again, I can see you don't know what you don't know. Okay, let's move on to the next question. Which comes, this is actually another email from Anthony here. This is more information. Tomorrow, the doctors want to end life support after only 4 days in ICU for my wife. She's only 35 years old. Perfect health, no pre-existing condition. Suddenly went into cardiac arrest, CPR within 2 minutes. EMTs brought her back to stable condition after another 8 minutes. Now she's got an anoxic brain injury. Arrival to ICU, first vitals, pressure looked amazing, the nurse told us. Now the doctors are saying no need to continue life support. I can't live knowing I didn't try to get answers. Doctors say they have no idea what happened. I don't believe them at all. Well, that's a good take there, that you don't believe them at all and that you do your own research. Now, I'm going to challenge you on something that you're saying here. I can't live knowing I didn't try my best. Well, I'm going to challenge you on that one. And sometimes you can try your best, and that may not be enough. You have to do what's necessary. And there's a difference there between doing I have done my best and between I have done what's necessary. There's a big difference there. It means you're taking full responsibility, right? And that's what every family in intensive care should do. And also every family in life, take full responsibility for the things that are happening to you, good or bad. That's how you live a life, and being responsible. In any case, Anthony, again, assuming you are the power of attorney, ICU cannot withdraw life support without your consent. Very simple. Very simple. And you should get a second opinion. You should get access to the medical records. You should let me talk to the doctors and nurses directly and find out what's exactly happening. ICUs are notorious to not even tell families half of the questions, half of what's going on, I should say. Right? On what grounds are they saying she shouldn't live? She's 35. right? She's 35. On what grounds is the intensive care team saying someone at the age of 35 should not be given time to try and recover them, right? That's madness. That is absolute madness. Yes, she's got an anoxic brain injury. What would she want? You haven't alluded on what would she want, you know. You're also saying CPR potentially only took 2 minutes, which is not a long time. If you're doing CPR for 5 minutes, after about 3 minutes of no oxygen to the brain, it suggests that there's going to be irreversible organ damage, irreversible brain damage. I don't know the ins and outs, but have you looked at the medical records? Have you spoken to a neurologist? Have you informed yourselves about your rights? It sounds to me like the intensive care team says to you, jump, and you ask how high. It needs to be the other way around. You are the client here. Okay, you need to change your approach, and you need to change your approach very fast here before it's too late. Okay, here is another email from Bila. Bila says, my mom is in ICU for a TBI from a car accident. The caseworker says she's ready to be discharged per the doctor's orders. However, I have yet to receive this news from the doctors directly. She has a TBI, a traumatic brain injury, and currently has a pneumonia and is still on the ventilator at night, and they put a trach in already. I'm concerned with what our rights are. They have not provided a plan for my mom's healthcare. When they send over a list of LTAC facilities, they only search requirement to add it was needs a bed. Right. Bila puts that in quotes, needs a bed. I feel they're just trying to push my mom out to a facility, as my mom's health insurance is not good and is very basic. The local LTAC facility has lower than a 3 rating. I want to make sure she's getting the proper care needed, not just being pushed off onto another facility, which will cause my mom to stop making progress. Yeah, the writing is on the wall here. This sounds very similar to Jessica's email a minute ago. Once again, just because they tell you he should be going to an LTAC, she should be going to an LTAC, doesn't mean you should be following suit. Your response to that needs to be, well, you have to have my consent, assuming you are the power of attorney. Ask them to keep moving your dad to get off the ventilator as quickly as possible. Get your mom mobilized, get her out of bed, and then hopefully she can be off the ventilator for more than 24 hours a day. And once that can be achieved, her options will increase, right? And clearly, they no longer have an interest in your mom. If they send over a list to the LTAC facilities and they say, oh, needs a bed, well, that's very basic. What about, the clinical condition, the discharge summary, and what needs to happen when your mom is at LTAC? It just goes to show that unfortunately your mom is just a number there. She's just a number there. She's not treated as a patient, and that's very sad. Also, with the pneumonia, she shouldn't go anywhere. She should not go anywhere until they've cleared the pneumonia. Very simple, right? Very simple. And if the LTAC has lower than a 3 rating, you shouldn't be going anywhere. And if your concern is she getting proper care, not being pushed off into another facility, which will cause your mom to stop making progress, you're right on the money. Don't send her anywhere. And you have the right to A, ask for the hospital discharge policy, B, not give consent. We have a document from a law firm in the US where it clearly says You know, patients can't go anywhere without, especially not to LTAC when they are ventilated with a trach, without patient or family consent. You have to demand your rights. You know, you can't just give in blindly. You know, another option might be intensive care at home. Not sure where you are located, but we might be able to help you even in the US with intensive care at home privately. So please reach out to us. Okay. Okay. Let's get on. Let's get on with the next question. The next question is coming from. The next question is coming from. Morgan. Morgan says, "Hi Patrick, my mom is in an LTAC after an emergent CABG, coronary artery bypass graft, that stands for, which she had at the end of August, and they said her 30-day stay is up and we can either take her home with a ventilator or take her to hospice. Before all of this, she had no prior health problems other than breast cancer 15 years ago, also chemotherapy and radiation. She had complications during a cardiac catheter procedure, which resulted in a coronary dissection and cardiogenic shock, which is the reason for an emergent coronary artery bypass graft, also known as CABG. She had multiple complications post-operatively, including bleeding, heart failure, and 3 days of CRRT. CRRT stands for continuous renal replacement therapy, also known as hemofiltration or dialysis. Her kidney function is close to normal now. She was on sedation for 14 of 21 days in the cardiac ICU before going to the LTAC. On admission to LTAC, we were told she had severe sepsis and 2 small strokes that were discovered once a CT scan was done at the LTAC, which also has an ICU. She also had to get a tracheostomy during her stay in cardiac ICU, since she was unable to come off the ventilator before getting to LTAC. Since the bypass graft surgery, the CABG, her ejection fraction is 40%, but we are now being told she has metabolic encephalopathy since she is not consistently responsive to commands and has been back on sedation for 14 of her 29 days in the LTAC ICU. She has also been failing her ventilation weaning trials. I believe this has to do with the fact she has been back on sedation due to anxiety and becoming tachypnic. The settings are FiO2 of 30% and PEEP of 5. We feel the ICU team in the LTAC are giving up on her because she's costing them too much time and resources. They are making me feel guilty, as if I'm making her suffer, but if there's any hope, I want to give that to her. Any advice would be helpful. Thank you." From Morgan. Sorry, not from Anthony, from Morgan. So, wow, this is a really complex situation. It further illustrates that you never should go to LTAC, even if LTAC has an ICU attached, right? We strictly advise against that, and she would be much better off in a proper ICU, right? LTACs don't usually have proper ICUs. Okay, let's break this down for you, Morgan. So it looks like your mom has a very long pre-medical history. And with that long pre-medical history, she should have never gone to LTAC in the first place. Never, ever, right? And to literally put the gun on your head saying, well, she should either go to home with a ventilator or to hospice, you know, that's not appropriate. Look, don't get me wrong. We could probably take your mom home with intensive care at home. We could do that, right? But I don't think they've tried hard enough to get her off that ventilator. That to me is not clear, because If she's on sedation, why would she be on sedation if A, she has a tracheostomy and a ventilator? One of the reasons you do a tracheostomy is that you don't need sedation, right? The other thing that's becoming evident here is if she's got metabolic encephalopathy, she is not consistently responsive to commands. Then she won't need any sedation. If she's got metabolic encephalopathy, she will be drowsy and unconscious, most likely. So why would she need sedation, right? Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Now, next, if her ejection fraction is only 40%, has a cardiologist seen her? Has a cardiology consult been done? I would think there would have been, especially with the history of coronary artery bypass graft operation. Right? I would think that would have been done, but you better find out. You know, and why does she have metabolic encephalopathy? Why? Right? Are you just taking it for gospel? You know, have you looked at the medical records? Do you even have access to the medical records? You know, we can give you a second opinion here, but we need more information. You know, it does not make sense that she's back on sedation, especially with metabolic encephalopathy. Does not make any sense. Right? And if she had complications during a cardiac catheter procedure, which resulted in a coronary dissection and cardiogenic shock, you know, that is dangerous. That is dangerous, right? For her to go to LTAC. She needs to be in an acute care hospital with a condition like that, not in an LTAC, right? And now, and here's another thing that most families don't know. If they do give consent to let their loved one go to LTAC, there's usually then a 30-day window, right? They have to get better in 30 days. And they already knew that she wouldn't get better within 30 days. But you didn't know that because you didn't do your research early enough. Didn't get a second opinion early enough. Right? So you're having multiple challenges here. Multiple challenges. If her ejection fraction is 40%, is she on inotropes or vasopressors? Right? And you're probably right. You feel that the ICU team are giving up on her because she's costing them too much time and resources. Yeah, you're probably right. They are making me feel guilty as if I'm making her suffer. But if there's any hope, I want to give that to her. Well, there's always hope. If there's life, there's hope. Now they are making me feel guilty. This comes back to my earlier point. You need to take responsibility for everything. If they make you feel guilty, it's you, not them. You respond to whatever they're throwing at you. Don't respond to it. That is your choice. You can't control them, but you are 100% in control how you react to them. That is what you control. You know? So as long as there's life, there's hope. You know? And you haven't mentioned anything about brain damage beside the metabolic encephalopathy. But then she's on sedation, right? If she's on sedation, you can't really ascertain whether she's going to wake up or not, right? The encephalopathy probably makes her drowsy, potentially unconscious, right? And she's on sedation. That doesn't make any sense. Why would you do that? You don't need to put someone on sedation who's already unconscious, right? Also, her settings are FiO2 30% and PEEP 5. Well, that's good. But is she breathing on pressure support, CPAP? Is she breathing SIMV, volume control, pressure control? Is she breathing AC, assist control? What are her ventilator settings? Right? But this is another reason why I always say do not go to LTAC. Never go to LTAC. Full stop. Okay. Let's move along to the next question. The next question is coming from Corinne. Corinne says, "Hi Patrik, my mom is on high flow oxygen, nasogastric tube for nutrition and water." Oh, my dad is on high flow oxygen, nasogastric tube for nutrition and water. He is aware and responding that he wants to fight. They want to remove the nasogastric tube and water and put him in hospice. Wow, that's powerful stuff. So let me read this out again. My dad is on high flow oxygen, nasogastric tube for nutrition and water. He is aware and responding that he wants to fight. They want to remove the nasogastric tube and the water and put him in hospice. Well, if your dad wants to fight and wants to have everything to be done to save his life, and they are going to remove the nasogastric tube to stop feeding him and giving him water and put him in hospice, I don't know how you would describe that. I would describe that as killing someone. I don't know what you describe it like. That's my description of it. That, in my point of view, is illegal, potentially a criminal act. So the question is, will you just watch it from the sidelines, or will you take action? And will you fight for what's right here? I leave that up to you, but I have to, I'm very blunt here. That is killing someone, and it's just not right. Right? So you need to take action here. I'm very happy to talk to them. I've turned many situations around just over the phone by talking to them, by reminding them of their duty of care, but also by educating you about your rights. Very, very simple situation here. It's a simple situation, right? You will need to stand up here for what they want to do. Unbelievable. You should be posting publicly which hospital this is, how inappropriate it is. But you need to take action here, and you need to take action very quickly. Let's move on to the next question. From Steve, who says, I feel hopeless. My wife is in a coma, has been for about 12 days. She bites down her tube and she opens her eyes. Lifts her right arm. It's curled and she squeezes her hand. She makes grimaces in her face. I know they're all just reflexes. I don't know how to feel, what to think. One day I'm okay, the next I feel like I'm dying. I feel lost. I feel like I can't go on. I don't know what to do. I miss my wife. It hurts me. If she wakes up, she won't be the same. I have so many thoughts. It boggles my mind. Okay, all right. So, if your wife has been in a coma for 12 days and she opens her eyes, well, that's a good sign. If she lifts her right arm, that's a good sign. If she squeezes your hands, that's a good sign. She makes faces and grimaces, that's a good sign, right? You don't know how to feel. Well, you need to take responsibility on how you feel. You need to take responsibility on what to think. You need to make a decision there, what you want to do. Do you want to keep going? Do you want to potentially pull out? What is it you want to do? It hurts you. If she wakes up, she won't be the same. Well, you don't know until she does wake up, and you won't know whether she wakes up or not until you've made a decision you want her to wake up, and until you've made a decision you want to carry on with treatment. Right? So your problem here is indecisiveness, not what's happening. You can't control what happens here. What you can control is how you respond. That's the only thing you can control. And the sooner you take charge of how to respond, the better it is. That's what you need to do. You need to take charge of how to respond. Okay, and once again, I'm very happy to talk to doctors and nurses directly to turn this situation around for you, to educate you on what's exactly happening, because the ICU team clearly has not educated you on what's exactly happening. Clearly, right? Get access to the medical records. Let me talk to them, and you will see that I can give you perspective, very different perspectives on what's really happening there. So I hope that helps. Now, next email is from Aja, who says, "Hi Patrik, thank you for making these videos and blogs. I really appreciate your work. We are currently in a situation with my dad having a cardiac arrest and being in a coma state for the past month and a half. He had downtime of roughly 10 to 15 minutes, but we aren't willing to let go. We didn't receive much support from the hospital staff, just the same things that you mentioned in your videos. From day one to day, we have seen many small improvements, and we're just hoping for the best recovery possible. Thanks again for the info and resources." Yeah. So you haven't given up, and that's a good thing. You'll only get peace of mind, power, control, and influence if you're not giving up. What's the purpose of giving up? There is no purpose in giving up, really. For those of you watching this that have children, if you have a child and you expect your child to walk after about 12 months, well, what if your child doesn't walk after 12 months? Will you give up? Will you say, well, my child won't walk, or will you keep trying? What if it takes 15 months? What if it takes 18 months? What if it takes 2 years? Will you say to your child, give up? No, you won't. And it's the same here. You can give up, or you can keep going, knowing full well that you've tried everything. Would that be a good feeling to have, knowing that you've tried everything versus knowing that you haven't tried everything? The choice is yours. The choice is absolutely yours. Let's move on to the next question. From William, who says, "Thank you for all your videos and blog posts. My brother is 35. He went into cardiac arrest 6 days ago while in the ambulance while on the way to the hospital. It took about 15 minutes and 7 rounds of CPR to revive him, but he hasn't woken up. They had him on propofol and Versed, which is known as midazolam, as well as fentanyl. Sedatives have been removed fully now for almost 40 hours. He's still on fentanyl on a low dose, responding to pain accordingly. He's reaching for the breathing tube in agitation. Somewhat looks at you when calling him. Not off the ventilator quite yet. He's breathing mostly on his own, but not quite ready to remove the ventilator yet. The neurologist said CT scan and EEGs look pretty normal for the most part. No signs of microclonus. Will he keep waking up little by little?" Well, William, this is a great email and a great description of your brother's situation. Will he wake up little by little? I would think so. I would think that he will wake up little by little. It's a bit like switching on a light with a dimmer, not with a switch. Recovery in ICU is a marathon, not a sprint. And if his brain is intact, then he should recover step by step, right? But you also you should be talking to the cardiologist here as well, making sure that there's not another cardiac arrest happening. You don't want another cardiac arrest happening here. You should be very positive here that he will wake up, but you also need to make sure what damage has been done to the heart, what has caused the cardiac arrest in the first place. These are really important questions for you to ask in a situation like that. What's his ejection fraction? What caused the cardiac arrest? Is he on inotropes? Is he on vasopressors? Has his blood pressure dropped to the point where his kidneys are potentially failing? Does he need dialysis? Is he at risk of having seizures? But more importantly, why did he have the cardiac arrest? That would be a really important question. Okay, let's move on to the next question. And this is more of a random comment from an email from Melanie that I had this week, who says, the hospital and the ICU is trying to send my husband to an LTAC, and we don't want that. You know, I mean, if you're watching this for the full length, and, you know, if you are on the live stream, you know, a lot of our US clients talk about, well, we don't want to go to LTAC. Yeah, then don't go to LTAC and exercise your rights. I have nothing else to say about that. Exercise your rights. If you're watching my videos, there's so much good information out there why you shouldn't go to LTAC and how it can be avoided, right? But once again, the shortcut here is to let me help you by talking to doctors and nurses directly, you know, by looking at medical records, and that will change everything for you. Okay, let's move on to the next question from Gillian, who says, my husband was taken ill 3 weeks ago. They thought he had a stroke. Then they diagnosed him with encephalitis, then meningitis. He's been confused, agitated, stressed, etc. He has had a CT scan which showed nothing, an MRI scan which showed nothing. They've performed a lumbar puncture which showed that the spinal fluid was clear. He's been put in an induced coma twice, treated with every antibiotic there is. He's in ICU and has been there for over a week. Any thoughts? That's a tricky one. So if he has encephalitis or meningitis and they've done a lumbar puncture and they found nothing, and they've done a CT scan of the brain which showed nothing and the MRI scan which showed nothing, then everyone seems to be at a loss here, right? So there must be something else going on and they haven't found out what it is. Once again, this is where a second opinion is coming in. You know, we can look at the medical records, we can talk to them directly, ask a series of questions. You know, what else is going on? Once again, ICU teams are notoriously renowned to not even share half of the things that are happening with families in intensive care. But that also comes down to families in intensive care. You know, they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. I would really like to talk to you, and I would like to talk to the intensive care team, and I would like to look at medical records. Surely we will find something there. But, you know, those would be the next steps. Just contact us here at intensivecarehotline.com so we can take the next steps with you. Okay, so let's look at the next question from Yasmin, who says, I'm confused. 1 minute my husband was okay, and they put him in an induced coma the next minute without my knowledge. Wonder what's happened there. Look, ICUs or emergency departments don't just intubate for the sake of intubating and putting people into an induced coma. They have strict parameters to follow, you know, when to put people into an induced coma and when to intubate them, right? So why did she go into an induced coma? I don't know, but something must have happened. Maybe she had a cardiac arrest. Maybe she lost consciousness for another reason. Maybe she stopped breathing. Maybe she had difficulties breathing, right? Maybe she had a VT or a VF arrest. Maybe she had a proper cardiac arrest. I don't know. You know, once again, from your email, I can see you don't know what you don't know. You know, you don't know what to look for. You don't know what questions to ask. You don't know your rights. And you don't know how to manage doctors and nurses in intensive care, because simply you're walking in the dark here. Once again, remedy here would be for me to talk to the doctors and nurses directly and or look at medical records. That would be the remedy here, right? People do go into induced coma in ICUs, but there must be a reason for it, and they either haven't told you or you simply don't know. You know, We have time for one more question, I think. That's too long. All long questions. Anyway, I think we can wrap this up for today. If you have any other questions while you're watching this here, type them into the chat pad. We have time for one more question quickly. If not, I am going to wrap this up here today. Thank you so much for watching. And also thank you for watching the replay. Now, if you have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of the website, or send us an email to support@intensivecarehotline.com. Like I said, we also provide intensive care at home services, and you can find more information at intensivecareathome.com. We currently operate all around Australia with intensive care at home, but if you're in the US, we can help you in the US or the UK as well. Please reach out to us. In Australia, we're operating all around the country, and we are also remote and rural areas. We also provide level 2 and level 3 NDIS support coordination. As a matter of fact, we are an NDIS approved service provider in Australia, also TAC in Victoria, iCare in New South Wales, and IISQ in Queensland, DVA all over the country, as well as we have received funding through public hospitals, departments of health, and private health insurances. So please reach out to us with any of that. Now, if you have a loved one in intensive care and you want your questions answered, we have a membership for families of critically ill patients in intensive care. And you can get access to that by going to intensivecarehotline.com and by clicking on the membership link, or by going to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also offer one-on-one consulting and advocacy for families in intensive care. And I talk to doctors and nurses directly. I ask all the questions to them that you haven't even considered asking, so that you can make informed decisions, have peace of mind, control, power, and influence. Now, when I talk to them, I ask the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care. I also represent you in family meetings with intensive care teams if you have, if you need representation. I know you will need representation. I also decide with you whether you should even go into a family meeting with intensive care teams, whether that's in your best interest, or whether you're setting yourself up for failure. I have been in hundreds of those meetings, and I know exactly when you should and when you shouldn't go into a meeting, and what conditions you should be setting if you even go into a meeting, right? We also offer medical record reviews in real time so that you can have a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Thank you so much for watching. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have. Thank you so much for watching. This is Patrik Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days. Merry Christmas to you and your families. Take care for now.